We're going to get started and I'll just admit other people when they join. Thank you everybody for being here. I know some of you have been on our talks before, but if you haven't, I'm Stacy Dillon, the co-founder and executive director of Connecting to Cure Crohn's and Colitis, and some of our team is here as well. Bracha, who's our community support manager, and some of our volunteers I see are here. And we're very excited to have Dr. Shervin Rabizadeh tonight, and I'm going to tell you a little bit about him. But first, I'm going to say that he is the Women's Guild Distinguished Chair in Pediatrics and Deputy Director of Cedars-Sinai Children's. He joined Cedars-Sinai in 2008. He did his medical training at Tufts University, and he did a lot of other things too. He did his gastroenterology fellowship at Johns Hopkins School of Medicine. And then he became the director of pediatric gastroenterology and pediatric IBD, as well as the medical director of the Maxine Dundas Children's Health Center Clinic at Cedars-Sinai before assuming his role as department chair in 2020. He is also my son's pediatric gastroenterologist, and even though Lowell's not really a pediatric, he's not at all a pediatrics anymore, he still sees him, and he's been a fantastic support to our family, not only medically, obviously he's excellent, but also just in all of the ways that we all know that IBD is difficult. He addresses all of them with his team at Cedars-Sinai and the IBD department, and we're very grateful that he's here tonight to talk about to better understand things that we always talk about, terms that we throw around in IBD that we may not really understand very well. Even myself, after 24 years of my son having this disease, I sometimes I'm still learning a lot about this. So we're very excited to have you here, and you can get started. And if you want to share your slides,
Yeah,
feel free.
thank you so much, Stacy. Really appreciate that warm introduction, and thank you, Braca, for organizing everything, and thank you everybody for joining. This is a exciting talk for me for a couple of reasons. I was just telling Stacy that beforehand, that this is the first time in a while that I actually had to make new slides because usually we have a whole bunch of slides I can pull out for any talk that we do, but this is a little bit different sort of approach and a different topic where I'm going to talk more about what do I hear as the common questions that are asked of us in clinic, and how do I translate that for folks to make it easier to digest. We have a tendency in medicine to use a lot of fancy words, terminology that sometimes is very confusing, that's hard to understand, but has been created over time um, to kind of help us in terms of figuring out a situation, like in this case with inflammatory bowel disease. But sometimes we forget that the patients don't speak that language, and we need to help you in terms of translation and so forth. So that's really the intention of it. Please ask questions, make it interactive. Happy to answer those, but let's see if we can go and see how that goes overall. So I put these common questions together um, in kind of thinking about what I've heard in terms of IBD in the clinic world. One of the first questions that's always asked or thought of is what's the difference between inflammatory bowel disease, IBD, and irritable bowel syndrome, IBS? They share initials, they share a lot of symptoms, they both involve the GI tract, but there's a very distinct difference between those two. And where I hear this the most commonly is when we are talking to a patient who has IBD and we're asking about family history. And usually there's some other family member in the room who says, "Oh yeah, I have that. I get those belly aches. You know, somebody diagnosed me with IBS." And so there's a lot of kind of interpretation of those things also out in the real world for us in pediatrics when the kids are in school and they're telling their teachers that I'm missing class because I have IBD. The natural assumption is it's IBS, and they don't understand this that well. So one of the key things is understanding that difference right there. Other things to understand is did do something to myself to cause my IBD? Are all my health issues due to IBD? Uh, should I know if I have Crohn's or ulcerative colitis? So we talk about inflammatory bowel disease having these two distinct disorders of Crohn's and UC. And should I know that I have which one I have? And when I talk about it, the big questions of can I be cured? Is it a permanent disease? Questions I get all the time from folks is that I just read this headline about a potential cure for Crohn's, for ulcerative colitis. What about it? And can we talk a little bit about that? And then some more practical things like what does it actually really mean to flare? When we talk about somebody flaring, what is that really happening inside the body? Do I need treatment if I feel okay? If I have no symptoms, what's going on and what's my goals of treatment? What does it mean to actually be in remission and what are the types of remission? And we'll talk about defining those. And what happens if I stop my medications? Why do I need follow-up tests? And is my treatment lifelong? So I'm going to try to really focus in on some of these questions as I go through some kind of slides about talking about IBD in general, talking about things like flares and remission, and even showing you a little bit of data overall and giving you some context. So, little background slide. We talk about inflammatory bowel disease, and we often describe this condition with two different types of disorders listed under it, one being Crohn's disease, the other being ulcerative colitis. Crohn's being inflammation that happens anywhere from mouth to anus. So it can be in any part of the GI tract, and ulcerative colitis being inflammation that's predominantly in the colon. And what I'm going to get to in a second is that this is nomenclature that is probably a little bit passé. And we here at Cedars are part of the groups that are proposing a little bit of a change in the type of description of what IBD is and getting away from this classic description of Crohn's and ulcerative colitis. And we'll get a bit into that. But regardless of what terminology you want to use, it's a dysregulated immune response. So it's your defense system going awry and attacking your intestinal tract. And you can have symptoms outside your intestinal tract, but the start of it is inside your intestinal tract, and that defense system attacking various areas of intestines and not churning off. It's staying ongoing response, that immunological response. We're talking about 2 to 3 million people in the US with inflammatory bowel disease, incidence of about 20 in 100,000, prevalence of close to 1%. And in the world of pediatrics, anywhere about 150, 200,000 children who are presently believed to have inflammatory bowel disease. And IBD is a big disorder for the pediatric age range, as 25% of those who are diagnosed in the pediatric age ranges, usually greater than 6 years of age. So that first question I brought up is IBD, IBS? What's the differentiators between them? And these are again, similarly named, similar initials. They're very distinct situations and disorders. And they're not, just because you have one, it doesn't mean you can't have the other. So inflammatory bowel disease is much less common than irritable bowel syndrome. So IBS, or irritable bowel syndrome, is in about 20% of the population, while IBD, we talked about it, is maybe somewhere in the ballpark of prevalence of 1% or so. Their symptoms, though, kind of cross over a bit with abdominal pain and diarrhea. IBS will have more constipation predominant. IBD will have more blood in the stools. But just because you're IBS and you have some blood from being constipated and having a perianal lesion like a fissure or something like that, you could see some blood in those sort of situations. IBD will have more weight loss, growth issues, fatigue, fevers, non-intestinal manifestations associated with it, while IBS will be more bloating, cramping, so on and so forth. So the big distinguisher is what they look like when we start doing testing. IBD will have abnormal blood tests that reflect that inflammatory process that's going on, abnormal stool testing. There will be inflammation on our endoscopic evaluations or on imaging, while IBS will have predominantly normal blood work and normal pathology. There's some work going on about certain immunological factors that may be involved in the process and some newer blood tests for that. But for the most part, we're not talking about the inflammatory load that you see with IBD. And the other sort of areas that big time differentiation, IBD's treatment is more involved in advanced treatments, advanced therapy. So whether you're talking about those biologics that you see 10 million commercials about, or sometimes some patients require surgery. There are some extreme nutritional interventions that are needed for the disease, and the disease is lifelong with some risk factors associated with it, like intestinal cancer and so forth. IBS, on the other hand, is treated more with lifestyle modifications, simple dietary changes or modifications, and certain medications like antibiotics for the bacterial overgrowth, antidepressant medications sometimes works for it as well. IBS is more of a quality of life function and less life-threatening, and no increased risk of cancer. So very distinct these conditions, sharing the same terminology, and so you'll hear that crossed over all the time. So back to our world of inflammatory bowel disease. You've probably heard this in talks before, and you'll hear it over and over again. IBD is a result of the union between genomics, the micro and macro environment, and somebody's inherent biology. And that leads to kind of subphenotypes of the disease. So what does that mean? Your genes being genetically susceptible, the environment you live in, whether that has to do with your gut bacteria, and that doesn't mean your distinct individual gut bacteria, but what the populational bacteria is, what has developed inside of you over many, many years, and so forth, like that. And other environmental factors from the outside. You're a smoker, or various other things. And then the biology is all about how that interacts with your immunological system, and then that leads to the disorder. Once the disease is churned on, once you have it, it's not going away. It's there. Now, it can be dormant. It can, quiet down, and it could be at times quite symptomatic overall, but it's still present with you for the rest of your life. We have not figured out a way of shutting it off once it has come about. So symptom presentation, for the classical definitions of like a Crohn's patient, they're more abdominal pain. For us in the pediatric world, we worry more about growth failure. And you can have extraintestinal manifestations such as perianal disease, so such as arthritis or skin lesions, fever, so on and so forth. For more the ulcerative colitis patients, you can get more rectal bleeding and diarrhea and so forth like that. If you look at what the presenting symptoms are, typically you're going to get belly pain in the majority of patients, diarrhea in the majority of ulcerative colitis patients, bleeding in the majority of ulcerative colitis patients. But a good number will have weight loss, especially with the Crohn's patients. In the pediatric world, you have that growth situation that we talked about. Mouth ulcers, we'll look at all those. And what I said a second ago was that there's a lot of extraintestinal manifestations of the disease. So what do we mean by extraintestinal manifestation? What we mean is issues related to the disease that are occurring outside of the intestines. So this is not the inflammation from the intestine leading to belly pain, diarrhea, bloody stools, so on and so forth. This is happening on your skin or your joints or your kidneys or your liver, so on and so forth. And the inflammation that occurs here doesn't necessarily have to correspond to your gut inflammation. So what do I mean by that? It means that the gut inflammation could be very well treated and quiet, and you still see these extraintestinal manifestations in some form, where others directly correlate with the gut inflammation being actively happen. And we don't understand this yet. There's a lot of work being done in the genetics and how the immunological system and the defense system works and how these things overlap. But that's one of the kind of mysteries yet to discover of why sometimes it's correlating with the gut and why sometimes it's not correlating with the gut. But though bowel is the second word in IBD, it is not just a bowel disorder. It can involve a lot of other health systems of the body. Also, the degree of the symptoms in that extraintestinal may completely outweigh that of the gut disease. What I mean by that is that the gut may be mild, and what you're getting in terms of the joint issues or the skin issues may be quite intense, and vice versa. So the extraintestinal manifestations that we often see, outside the pediatric range of growth failure would be more the joint involvement. So sacroiliitis would be that lower back area joint complaints of that pain right there. You can get osteoporosis and osteopenia. And then you can get things that are more specific to the liver, like primary sclerosing cholangitis. These are skin lesions you see here. That picture with the wound right there is what's called pyoderma gangrenosum. And then the one to the right of that is erythema nodosum, these painful red bumped areas right there. You can even get findings in the eyes. So episcleritis is the picture of the eye that you see there. Um, all right. So I alluded to this a second ago and said that, our work in the world of inflammatory bowel disease has come a long way. Not just from the medications and the treatments that you've seen over the last 20, 30, 40 years, but also our understanding of the disorder in general. And one of the things that we're coming to a conclusion is that our terminology of Crohn's disease and ulcerative colitis is probably not the best way for us to group our patients together. And the reason for that is complicated, but some of it is because what we thought were two different distinct disorders, there's a lot of overlap between them. So if you look at just something like genetics, and we've looked at genetic changes in IBD patients, there's about some 250, 300 out of the 350, 400 genetic defects that have been identified in patients that overlap between what we've classically defined as ulcerative colitis and Crohn's disease. And if you look at how we treat these disorders, the treatment of them overlap heavily between between both of these conditions. And it's more about where the patient's inflammation is. What other extra factors do they have involved, the extraintestinal manifestations and so forth. So there's a movement in the world of IBD research and IBD work that you may see kind of changing the way we talk about this disorder and coming up with a new kind of nomenclature where we're talking about different types of IBD as opposed to ulcerative colitis and Crohn's disease. So don't get confused if in 5, 10 years you start hearing the gastroenterologist talk about you have IBD type 1, you have IBD type 2, IBD type 3. And the lumping there is lumped together based on, IBD ones are all patients who only have colonic disease, but no deep ulcers, let's say. IBD2 are patients who have small intestinal and large intestinal colonic disease, so on and so forth. So that's the kind of groupings that are happening. And the importance of this is in terms of treatment, because what's important is not the treatment based on the nomenclature of ulcerative colitis and Crohn's disease. What's important here is the nomenclature is that actually using similar patients in their phenotype, how they present, and they usually respond in experience to treatments in a similar fashion. And some of that lumping may be also with the genetics, and some of it may be more sophisticated testing that's happening in the background where you are using precision-based approaches for patients and looking at certain protein markers, certain other omics that we call it, these interesting sort of testing that you can do for patient populations and grouping them together, and that can give us a little bit of better sense of how to treat patients. So this just shows you in a different way. And part of the reason for this is one of the things that we have struggled with for the years, and I'll show you this in a second, is that all these medication treatments that come out and that are approved for treatment of IBD are not universally successful. In fact, the rates of success are on the lower end than 50 percentile or 50% for the patients to respond to it. And part of the reason why is that it is a heterogeneous disease, meaning that not all what we classically call Crohn's patients are the same. Not all ulcerative colitis patients are the same. And because of that, their biology is different. The way they present is different. Their manifestation of their inflammation is different. And we should be changing the way we look at it and think about how to regroup them up so we can be more successful in treatment because we're aggregating people who are more similar instead of going towards a nomenclature of Crohn's and ulcerative colitis. So one of the ways that we do that is mention genomics and so forth. Another is just based on symptomology. So sorry, it's based on symptoms and based on various patient factors overall. So you hear us say in clinic that your risk for a complication of the disease is higher. Well, what does that mean? Well, what that means is that, what we're looking at is predictions about whether or not your disease is of a more aggressive nature that is going to lead to something of a complication. So for patients with developing scarring or stricturing of their intestines and obstruction type of issues, or patients developing those extraintestinal connections that are called fistulas, which is this like kind of tunneling that happens out of the intestines and finds its way somewhere else, most often around the anal area out there, but it can happen internally as well. Or risk factors for colon cancer, so forth. Or risk factors that your colon is going to be at an inflammatory load that's just too hard to control and none of the medication is responding, and that you're going to need actually surgical intervention. So what you see here is listing of various conditions like that, like young age of onset or small bowel disease, or having a high amount of weight loss. These are all risk factors for us to have more aggressive disease. And just an example of that, of the discussions we have in clinic of saying, hey, listen, I'm more worried that your disease that we just diagnosed is on that aggressive front, and we're going to have to really factor that into kind of the treatment. And when we talk about treatment, I did say this a second ago that now we're in the era of precision or personalized medicine, which really is this concept of choosing the right therapy for the right patient at the right time. So whether it is based on your genetics or those omics we talked about, or whether it's based on the location of your disease, or whether it's based on those factors I just quickly showed you as an example of making it that you have more aggressive disease, all of those should dictate to us what recommendations we have for the therapy that's best for the patient. It should be right for the patient at the right time and that right therapy. And in this day and age, we want it with trouble-free reimbursement, given that these are very expensive medications and the life-altering, life-saving in a lot of respect. And this is the era that we're in right now of this, what we call precision medicine approach, trying to individualize the treatment based on certain characteristics of the patient. Um, Others have really talked to you about, and I'm not going to talk to you about these medications of what are the approved therapies in inflammatory bowel disease from a drug perspective. I'm not even touching on the nutritional therapies that exist out there that are possible as well as some of the other alternative sort of approaches as well. But just give you a list that, this is reflective of a growth in the number of drugs that we have had over the last 30, 40 years. So there's much more options for our treatments and so much more need for us to be able to have that precision approach where we pick the right treatment for the right patient at the right time. I'm a pediatric gastroenterologist, so I always have to make the plug that there's only now 3 approved drugs in pediatric IBD. So these are all approved in the adult age range. But we just recently got approval of vedolizumab in pediatrics, but infliximab and adalimumab are the other ones for peds. All right. But when I talk about these different therapies and the life cycle for which it takes to kind of get these medications to treatment, I wanted to give you a little bit of sense of that. And this is to that question of, I just heard about this new fantastic treatment that somebody did a headline about and said it's going to be revolutionary. And most of the time you're seeing those headlines in early stages of a treatment coming through the process and not yet really ready for clinic. But to give you a little bit of a sense of a roadmap of what it takes for a drug to get approved, to get through, and how a drug is discovered, you can see the complicated meandering road in this kind of graphic that shows what happens overall. It starts on that left side, bottom left side of the screen with an idea where you're doing some exploratory sort of look and you have noticed something, whether that's through biorepository of patients or you notice something clinically or something of that sort. And then based on that, there is that synthesis of compounds, bringing it together and trying to explore how you're going to manipulate that area that you're focused on. And this is all happening in the laboratory in what we call in vitro. So meaning that it's on cell lines or different sort of experiments in that way right there. And then from there, you start screening different potential compounds or chemicals or drugs that could manipulate whatever you're noticing in the laboratory about something that's gone awry in the biological system. And this is all the discovery phase of this. Once you've identified that compound that you think will be the rock star, then you take it to the animal models. In this day and age, we still go to the animal models, though the FDA may be pushing us away from that and going into models of like what we call organoids, which is organs developed from different cells, something we do here extensively right there. But you put it into animal models of the disease, and that is really looking at the mechanism by which the medicine may work, potential effectiveness of the drug, though animal models are not great replicas of actually human disease and inflammatory bowel disease. And you're also looking for safety of that drug. Then you start going into human testing of the drug if it passes your animal models. And you start with what's called phase one studies. So, phase one studies, you're really making sure that the drug is safe into humans. Um, and it's a small population of patients that are in that study, and you're looking for safety. Then you're moving to phase two studies. And phase two, you're more looking at how to find the right dosing of the patient. So you're looking at biomarkers and bioavailability of the drug and so on and so forth, and trying different doses. And these are larger than the phase one studies by about tenfold. They usually have about 100, 300 patients right there. And then ultimately, you're getting into phase three studies. And the phase three studies is where you're doing a placebo blinded study. So you're taking a subpopulation larger than the phase one studies, and you're giving some sugar pills or the vehicle that the medication is in, and others the medication that it's in, and analyzing the difference between them. And then based on that difference and showing that difference right there through that analysis and so forth, that's where you're proving that the drug is effective, all the while monitoring side effects, making sure that it's okay. And that's the data you take to the FDA for approval of the drug, and the new medicine comes about. Once the new medicine is approved, you might hear of something called a phase four study. And what a phase four study is, the drug is out, it's being used in a patient population, but they're still monitoring to go on to make sure that it's working the way you think it's working and it's not causing any long-term side effects. So usually that runs over 5, 10, 15, 20 years sometimes right there. This whole process takes somewhere in the ballpark of about close to 20, 25 years to get through that. Now, we're trying to accelerate that in this day and age, but still, it is a long process to get a drug to market right there. And for every one of these sort of drugs that gets through this process, I apologize, my slide is not responding to me. There we go. There are many more that actually fail through the process. So each one of those steps could be a hiccup point for a medication going through with it. So sometimes when you see the headlines, it's because it was on the laboratory base, or it was on the animal base, or it was early phase one trials, so on and so forth. But it takes a lot to get a drug through. And so, you look at various pharmaceutical companies, they have a huge list of drugs that they're pushing through because they're banking on one getting through and many more not being successful as it goes through the process right there.
Hey, Dr. R, sorry,
Yeah,
can I ask you a question actually, just
yeah,
because I thought it was interesting. That's interesting. So if they find a pathway that, someone has an idea, like you said, it
yeah.
started with, does that always lead to then find a drug that can address that pathway? Or is the research sometimes around the other things that we talk about with IBD, like gut microbiome?
Yeah.
Do you
So,
understand my
yeah,
question?
yeah. No, I understand your question. To be honest with you, pretty much even those pathways that you're like studying the gut microbiome or anything of that sort, in the end, it is to get to the point where you have a treatment or a drug to market. So
Right.
even those are focused on that. And the way they focus on it is more, it could be just understanding the biology of the disease and to understand what are the factors involved that then helps you develop something around that. Or, as was the case, probably about 15 years ago, so there was a bunch of different companies trying different microbiome products for the
Mhm.
disease as well.
Yeah.
So even there, they're trying to get through this pathway because that's the end result for them to get through it. Academicians, people like us in medical centers, you will get people who are just trying to understand the biology of the disease. They're not pushing through this. But once it gets to that stage, the drug companies are going to want to take it all away.
Okay. Thank you.
Mhm. All right. So this is an example of something that you guys are going to hear about very soon in the next couple of years that will get likely approved for inflammatory bowel disease. And that's something that, my mentor did the majority of work here at Cedars-Sinai for the TL1A pathway of a drug. So TL1A is just one of those, it's called the super family of TNF type of pathway. It's another immunological, another defense pathway that was discovered as a potential instigator in certain inflammatory conditions, in this case, inflammatory bowel disease. And you can see that, and I'm sorry, the time graphic has changed, but this is, if you can see it, 2004 was the original studies of looking at this receptor for TL1A in patients' bloods from ulcerative colitis and Crohn's disease patients and discovering that this may be a pathway of interest. And then it went on through many years and the mouse work and so forth. And then our development of actually a drug of it, an antibody drug, an anti-TL1A drug right here. So that was closer to about 2017 and stuff, 2016 or so, 2017, and then going into more recently the phase two studies all the way in 2023. So that's a 20-year timeline that has existed. This drug is in the hands of Merck Pharmaceuticals right now in phase three trials, and their phase three trials should be closing soon. And given that the phase two studies looked very good in the drug, we anticipate that this will make it through and be available in the next couple of years as a new pathway of treatment. One of the things that we really liked about developing this medication is that it actually has an accompanying biomarker. So it has a test, a blood test that can help us predict better who is going to actually respond to the treatment, to the drug, and kind of tip those odds more in favor of picking the right patients for the right time, treatment for the right time. Um, and that speaks to this. I alluded to this earlier. I've shown this slide before, and this is what it looks like at clinical trials right now. Here are, four drugs that are readily available for treatment of inflammatory bowel disease: adalimumab, infliximab, vedolizumab, ustekinumab, and they're the trials, the phase three trials that went in to getting them approved. And what you see in the boxes for vedolizumab, 18%, for ustekinumab, 36%, infliximab, 17%, and adalimumab, 25%, was remission. And we're going to get in a second about what remission means, but remission of patients who were on the drug. So, 75% plus of the patients did not achieve what we wanted them to achieve, which was remission. But yet these drugs were what was approved because they did remarkably better than placebo and we didn't have anything around. Now, real life, we've gotten much better, again, through all this precision-based work that we do currently in helping us predict who's going to be more successful, what treatment you need to be on. But, it gives you a sense of where we're at in terms of when you hear about drug development, so forth, and why we talk about having this precision-based approach. Okay. So let's change gears a little bit and talk about some of the terminology that you hear a lot of. So, first one that we're going to go through is, what is a flare? It's exactly as it sounds. It's a period when the symptoms worsen. So The symptoms that you see worsening usually follow those that you had at original presentation. Meaning, if you are a type of patient who has bloody stools and that's how you present it, usually your flares are bloody stools. If you were a patient who had more belly pain, then usually your flares are more belly pain. Doesn't have to always be the case, but it's just the majority of the time that's going to be the case. A flare is a time when the inflammation becomes active. Um, you could have a flare, though, without symptoms happening. So there could be some smoldering inflammation, and we'll get into this a little bit, that is not showing up in symptoms yet, but there's active inflammation all along. And typically, flares happen because you had a time period where you did really well, that you were symptom-free, inflammation-free, so on and so forth. And as we said earlier, IBD is a lifelong condition. So our goal for treatment is to have long periods of remission with no flares, not even fewer flares, but no flares. That's when we know we're in the control of the disease overall. So that's our treatment goals. So our aim is to keep people in remission. And we're going to talk about that, why that's the case, and what do we mean by remission, and not just symptom control. Symptom control is important, but remission is more important because that is what's going to lower the risk of flare-ups for you. We take this approach called treat to target nowadays. And what that means is when you have a patient who's initially assessed and so forth, we have a target of what we want to get to in their treatment course. And we reevaluate based on that target and we change or adjust treatments based on not hitting that target. So the target, as we'll talk about in a second, is treating the inflammation such that when we look for that inflammation, it's not present. That's often a target of ours. So if that's the target and we're not getting there, then we're going to want to achieve, we're going to want to change that treatment regardless of if you're having symptoms or not. Why? Because leaving that little inflammation behind could put you at risk for complications down the line. We want to maintain that remission with regular monitoring, and we want to prevent complications as much as possible. So I mentioned a second ago that our goal is to get to the point of that target. And the number one target that we are striving for is something that we call mucosal healing. And that's where the intestines look back to normal on the treatment. And in the short term, so this was a study called STRIDE 2, and STRIDE 2 was a study that was designed based on grouping together of a lot of bringing together what we call meta-analysis. What a meta-analysis is that you have smaller studies that have been done over the years, and then somebody aggregates all the data from those together and tries to coalesce them to draw a more powerful conclusion based on higher numbers. So Stride, what they did was they did that and they brought an expert panel together and they came up with kind of what the recommendations for treating inflammatory bowel disease, not what medications you should be on, but what the goals of treatment should be at various stages through the course of the disease based on all of the data we know scientifically and this expert opinion right there. And what they talked about was in the short term, the goal is symptom control. In the more intermediate term, we want to see normalization of blood work markers like the C-reactive protein and the sedimentation rate, or stool markers like the calprotectin. And the long term, we want to get to what's called mucosal healing, which is when I look back with a scope, I don't see any inflammation at all. And that's the treat to target approach, is getting to that point of mucosal healing right there. And doing that is associated with the best long-term outcomes, the least amount of complications of the disease in the long term. And then I want you to remember the short, intermediate, and long term because it's going to come up really important when we talk about remission and how we define remission overall. The CALM trial similarly showed, used a different methodology to show similar things. And what it showed was that when patients were followed with their symptoms and their biomarkers, their blood work and their stool testing and so forth, excuse me, they were much more likely to have that mucosal healing endpoint when they were controlled tighter based on those things, as opposed to standard of care when somebody was just saying, okay, you're feeling a little bit of this, that, and the other thing, that then let's adjust it. But when we added in the blood work and the stool testing to it, the patients did better in the long run, and this will become important in how we monitor disease status overall. And then, really important with this study was that when you were mucosally healed, you were most likely to stay in that status. So, again, proving this point, if we can get to there, that's associated with the best long-term outcomes overall. And this was replicated in this study, which was another meta-analysis study that bringing all these different studies together that showed that, again, if you had reached that mucosal healing, you had less likely to have surgeries, less likely to have hospitalizations, less likely to have relapses, less likely to have steroid, and you were more likely to kind of continue to stay that way over the long run. So it always favored this mucosal healing. So because of all of this, um, well, before I get into that, let me just talk a little bit about durability. So you hear this word, sometimes we talk about durability, and durability is that ability to stay in that remission state without a loss of response to a treatment. And as drugs have been further developed over the years, the drug's ability and the treatment's ability, I should just expand it beyond drugs, just treatments in general with how we do it nowadays to maintain that durability has improved. Some of that is because we've gotten better at being able to monitor drug levels or maintain the course of treatment and identify risk factors like we talked about. Some of it has to do with the biology of some of these drugs being changing over its time. So the durability of the older advanced treatments like the anti-TNFs, like the infliximab and the adalimumab, was lower than some of the newer treatments that have much less secondary loss of response. And this is where we make a big plug about adherence. All of this is predicated on somebody adhering to their treatment, staying on that course of treatment. And the graphic on the right is what you see when we have durability, adherence, all of these things come together. That tight control and monitoring, as you saw from the previous studies that show achieving that mucosal healing makes it less likely for you to run into complications of disease as opposed to others who are waxing and waning on their treatment overall. Okay, so putting that all together, then let's talk about the word remission and what does that mean? Does remission mean cure? Some in the GI field feel that we should equate the two because if we have achieved the ultimate sign of remission, which you heard me say was that mucosal healing right there, it's like you're cured, though you have to sustain that on. You have to sustain the treatment regimen you're on from that perspective, right? But when we talk about remission, we kind of divide the world into various types of remission. So back to that study I told you about, feeling better symptom-wise, that's clinical remission. I feel well. In that kind of intermediate phase where my blood work and my stool testings are looking good, that's biochemical remission, where I'm seeing those markers improved and stuff. But the ultimate goal of remission is reaching that point where you are in endoscopic remission or mucosally healed, which is when I look with a scope, everything looks normal. Or imaging, if that's where your disease was diagnosed, looks normal overall. The controversy right now is whether that's good enough or we should be in something called deep remission, where there's been histological healing, meaning the biopsy specimens don't show anything active going on either. So not just that they're visually normal, not just that they don't have any symptoms, not just that their blood work is normal, but histologically everything is looking good under the microscope. And then we get into the next phase of remission, which would be more that precision base for the future, which is molecular healing, which is looking and seeing, did we change the signature of these very fancy molecular testing that we can do nowadays that are not ready for prime time in clinic, but we do it in the research modes, but will be coming at some point, and whether that's reflective of those remissions. Okay. So again, from those previous studies, you saw the importance of getting to that mucosal healing state, and that's the terminology of remission that we talk about. So why does remission matter? Well, we want to feel good, better quality of life, of course. That's that clinical remission. But when we're in that remission state, it allows the body to focus on other functions. For kids, they can grow. Uh, Regular menstrual cycles, ability to promote a healthy pregnancy, so on and so forth. We talked about multiple times that mucosal healing is the strongest evidence and better outcomes. So that deep remission is where, or that endoscopic remission is where we want to get at. And this is all because it reduces the risks of disease complications and decreases our cancer risk associated with it, all the risks that we associate, avoiding hospitalization, avoiding steroids, so on and so forth. What happens without control? Well, the opposite. You're going to have, symptoms, and then you're going to have the risk of strictures or scarring or fistulas or surgery or cancer, just not feeling well, so on and so forth. Weight loss, everything that you would associate, malnutrition, so on and so forth, things that we can want to avoid. And thus the importance of that word remission. But again, how do we find that word and where do we want to get to with that endoscopic or mucosal remission right there? Okay, a little plug about monitoring in all of this. How do we know that you're getting to where we want you to do? Well, we have to monitor you. So yes, it's great that you don't have symptoms, but we also want to make sure that your blood tests look okay, your inflammatory markers there, your calprotectin. Nowadays, we have the capabilities to do a lot of bedside, clinic side intestinal ultrasounds, a really good way to look at the end of the small bowel and most of the colon, and very predictive of what the scope would look like. Hasn't replaced it completely, but complements that overall. And then we've talked about that goal of getting to that mucosal remission, endoscopic remission, so requiring that periodic endoscopy and or imaging sometimes like an MRI or something like that if that's what your disease look like, again, to get to that landscape. And then I'll end right here with my last slide just to bring it back together. I've shown this before and because we believe in this overall. But in this day and age, you're going to hear us say a lot about having this precision-based approach, and where we want to get to, what the future of the world of IBD would look like is to be able to help you and help the patients by doing the history, figuring out what the symptoms are, all those different sort of characteristics of the patient overall, analyzing samples based on their genetics or the other omics and so forth, proteomics and metabolomics, their gut microbiome, everything like that. And then using that to generate this composite score of what their IBD would look like, which would then help us in a prognostic factor of telling you where your disease is, what your risks of the diseases are, and then helping plug that into a menu of therapies that may involve manipulating your microbiome, your diet, your medications, so on and so forth, the non-prescribed medications as well. And all of that with the goal that this early intervention, individualized, durable treatment to prevent progression to a more severe form of IBD, to reach that goal state of that mucosal healing, that remission that we talked about right there. That's what we want to get to. And that's what it's about for us at this point right now in helping our patients and changing those numbers where we get better response rates overall. So, hope I made some of these words a little bit more clear for you. I know they can be complicated. Hope you gave you a sense of how drugs are developed and how things get to market, and happy to answer any questions.
That was that was great. It was really good. And even like some of the things, like I was always confused about like treat to target, and you explained it really well. So, like I said, I'm still learning things. I think there's a lot of questions in the chat, but I'm just going to ask two that we got from registration. If we don't get to all the questions, we'll try to follow up with you. But
Sure.
someone asked, and you mentioned this, the extraintestinal manifestations, but someone asked if the GI tract is in endoscopic remission, but they still have extraintestinal symptoms. What do you call that? What do you consider that, and how do you manage it?
That's a great question. We don't exactly have terminology that fits that perfectly. So there we would actually kind of be more descriptive and saying, hey, the intestinal inflammation is in remission or under control, but your IBD in general is not, because you have those extraintestinal manifestations.
Mhm.
And like we talked about, even though again, that second word is bowel, this is a disease that involves more than the bowel. So we have to factor those into the equation of treating the patient. And that should be part of that discussion about what are we doing for whatever the extraintestinal manifestations are. So we don't have great differentiating terminology, be more descriptive in that situation, but it needs to be addressed.
Yeah. I mean, like, I know you would refer to another specialist for like joint pain or eye
Yeah.
issues.
Yes. So
Um,
dermatology, ophthalmology,
yeah,
rheumatology, all of them are involved in the management of some of those, depending hepatology for the liver, so on and so forth.
great. Um, I'm wondering if Heidi, you could unmute yourself and just ask Dr. R the questions because you put some questions in the chat and I don't want to get them wrong. Do you mind doing that? Um, but meanwhile, someone also asked about, oh, did you? Oh, yeah, I can hear you.
Yeah, one of the overreaching questions I have is what are the barriers to developing drugs that are more effective and safer profile? It seems like with these small molecules, you've gone in the other direction of, not as good safety profile, and the effective rates really haven't improved that much.
Yeah, I think very good question right there. Um, W- I would tell you some of the barriers have to do with the disease. As we talked about, it's the heterogeneity of that disease. It's the biology is not the same in most patients. They're all over the place, and because of that, you're targeting different things overall. One of the other factors, I didn't show you this. We have this slide that I like, and it shows you that what we probably didn't appreciate and understand early on is that some of these drugs and the way they work is that they work on certain specific factors in the immune system, taking out certain proteins and stuff like that. Body's very smart. And you take out that, other systems rev up. And those other systems may be contributing to inflammation as well. So then you start looking at, drugs that hit multiple fronts, and maybe that would be more successful. And we like talked about with the TL1A story, it's really trying to identify factors that help us in the groupings of patients together to increase that success overall. In terms of the side effect potential of some of these medications, though the small molecules do have potentially a little bit more side effect than some of the older biologic drugs and stuff, the difference is really not that much. They're proving rather safe. They have some distinct sort of differences, but overall they're proving safe. And in terms of their efficacy protocol portfolio right there, their efficacy is getting a little bit better, and especially again if you're using it in the right patient at the right time. So it's not the perfect answer for you. It's a great question right there, but it's really the deficiencies of where we're at in terms of understanding the disease fully. But as we get better and better in our precision approach, I think you'll see a change. I think you'll see that effectiveness going up and up and up.
You also asked some questions about the small bowel, Heidi, which I think some of us are interested in because our kids or patients have small bowel disease. And you asked about, well, you asked about like, uh, consider isolated small bowel with no symptoms, a unique disease, and are there any drugs that target the upper small bowel?
Yeah, great questions overall. So, yes, do I consider that a unique disease? Remember, we talked about those different phenotypes. It would be a phenotype by itself.
Yeah.
Mhm.
And even we got to go a little bit further than that because small bowel is 15 feet long. And the disease that presents at the end of the small bowel in the terminal ileum is probably different than the disease that's happening higher up in, like, let's say, the beginnings of the small bowel in the jejunum and the upper GI tract and so forth. So even if you look at our characterization of, like, even in trials where you see a descriptor of patients, we've always distinguished those as well in like different classification schemes and so forth like that. And the response rate of these and how they behave is different from that standpoint. Um, uh, when you're talking about the small bowel, you are going to gear your treatments more. It can be a little bit more difficult at times for that more extensive small bowel disease, and you're going to gear your treatments to higher level advanced treatments. So those biologic drugs. There's a question of whether the upadacitinib, the newest small molecule right there, has as much efficacy in those higher up small bowels. You actually bring in some of the older drugs that we used a while ago that have huge side effect, different portfolio like thalidomide and medications like that for that upper small bowel disease because it is a distinct entity right there. But that's a disease entity that could be more aggressive. Unfortunately, we see it more in kids than in the adult world, and thus we are more aggressive in terms of their treatment, as opposed to self-limited end of the small bowel terminal ileal disease that maybe you can even be on something like a budesonide, a local treatment of a local steroid right there, and that can handle that for you right there.
Thank
Um,
you.
may I ask how you monitor the upper, like jejunum? How we do you monitor that?
Yes, you're going to monitor that. Uh, you will follow the testing that showed you the disease to begin with. So if you did have an elevation in blood inflammatory markers and so forth, you're going to follow that. Less likely that stool calprotectin is going to be reflective. That can be at times, but less likely. You certainly are going to follow it by endoscopic methods. So whether it's shown on the upper endoscopy or something called a push enteroscopy, where we go a little bit further, a double balloon that's further. But probably one of the better ways is small bowel imaging. So whether it shows up on your MRIs, your MRI enterography and stuff, or the pill cam, the capsule endoscopy, the things that you swallow that travels through and takes a whole bunch of
Yeah.
pictures of your small bowel and transmits those. That's probably going to be your best way of looking at small bowel disease, unless you have scarring, stricturing of the small bowel, which in that case, you're going to use your cross-table imaging like your MRI.
How often would you do a pill cam?
So, okay, it varies between your clinical situation overall. So, I certainly want to do some sort of reevaluation of the disease and see it's responded to my treatment, treat to target. So, my
Right.
target was to treat that inflammation. I started you on a new therapy. I want to repeat that pill cam within 6 to 12 months of starting that sort of regimen and see if it's worked. Okay. And then from there, you go from there. And it depends, right? If I need to adjust my treatment, I'm going to do it more frequently because treat to target. I want to see if the response. If I've reached my remission point and I can follow your blood work, then I might not do it as often. I might do it every couple of years or something like that. It just, you go from that first one.
Okay.
Thank
Thank
you.
you.
Thanks, Heidi. And we can also follow up with you with some of the other questions. But I did want to say you had a question about, I think, about diet and studies of optimizing drugs, and there definitely are. We can send you or connect you more about the diet studies. And then someone asked a question about how accurate is fecal calprotectin. You sort of touched on that a little bit, reflecting inflammation in ileal Crohn's.
Right. So fecal calprotectin is detecting a protein that's coming off of inflammatory cells, neutrophils, that don't belong in your intestinal tract. But as a protein, it will degrade uh, as it goes through if it sits too long, so forth. So calprotectin is going to be more sensitive and specific, meaning it's going to be better at detecting and less falsely negative. The more further down your GI tract, the more distal your disease is. So the further you're on the large intestine, the calprotectin is going to be more sensitive. As you move up the intestinal tract back towards the mouth right there, the calprotectin becomes less and less sensitive because longer way those neutrophils are traveling and that protein may degrade in that time right there. It doesn't mean it doesn't work for them. It just means that it's a better test for the colon, the large intestine, than anywhere else. Again, it's a good test to get at the beginning and throughout and see how it relates and something you can follow. No one test is going to be perfect, so you just have to monitor it.
Thank you. Stephanie, who asked the calprotectin question, also asked about peripheral neuropathy, if that's an extraintestinal manifestation, or maybe that's a drug side effect, I was thinking. I don't know.
Yeah, so I would tell you that all three are possible. So peripheral neuropathy in an autoimmune fashion could be an extraintestinal manifestation, uncommon though, as the extraintestinal. Could certainly be a drug effect. could also be a completely separate entity altogether, not related to IBD.
Thank you. Okay, I know we're at time. I'm just going to ask one more question. Someone just asked about probiotics and VSL number 3. I don't know if that's still around, but I don't
Yeah.
know.
The probiotic story, just not great data for it just to support it has a fantastic efficacy in changing it. Side effect potential is pretty low for the most part, unless you're really severely inflamed and your gut barriers are broken down and you're introducing more bacteria in the system. Maybe a little bit of a role in, no, there's some data for it to suggest maybe in patients who are post-surgery, post-removal of their colon colectomy, who have a pouch, internal connection of their small intestine, and they get pouchitis, pouch inflammation right there. There could be some potential role in there. There could be maybe some potential role in the kids at a younger age with very mild disease, but nothing that I would stand too much around.
Mhm. Okay, one more question because this person messaged in the chat about Rinvoq. You talked about it a little bit. I think it's how effective is it and could it be used in combination therapy? Because if you're still having symptoms and you're on it, would you use it in combination?
Yeah. So great questions overall. Upadacitinib for both UC and Crohn's shows effectiveness that's similar to the other drugs that we've had around, maybe a slightly higher in the colonic sort of patients, the UC patients and the Crohn's patients. The combination therapy approach is something that's really gaining a lot of interest from us nowadays for the more refractory patients who are failing treatments, have more aggressive disease, so on and so forth. So using a combination approach, whether that's upadacitinib with another treatment like vedolizumab or with an IL-23 like guselkumab or risankizumab or mirikizumab, are certainly something we do. It's not something you would do right off the bat. It would be something that you're doing because your patient is refractory, not responding the way we want them to respond and has failed multiple treatments and so forth right there. But it goes back to that graphic I didn't show you where you have other pathways coming up when you use one drug, and maybe you need 2 or 3 drugs to kind of suppress that overall. You're counterbalancing that with the side effect potential of more immunosuppression. Does that create side effects and so forth? So far, so good. Again, not to the point that we would go right off the bat to that, but showing some promise that it could be a good approach for patients who don't have many more choices, no alternatives because of what they're failing.
Yeah. Wait, if you can stay for another minute, I have 2 more
Sure.
questions. One, I forgot to get to Betty's question, which was, is it considered mucosal healing if you have all normal labs and colonoscopy looks good, but there is microscopic inflammation?
Oh, great job, Betty, for asking that. And obviously, I didn't do a good enough job of explaining it. So that is mucosal healing. What you see microscopically on the biopsies, you would not be in deep remission. Okay. And that's where the controversy exists right now. Is mucosal healing good enough, or do we got to go to deep remission? And the jury's still out. We don't know yet. Okay. And what I would say to that is right now, I would take a practical approach. Depends on what it looks like on the biopsies. If the biopsies are showing you a little bit of mild activity here and there, I think you're good, right? But if it's showing you more intense, more moderate sort of inflammation right there, that may be something worth a discussion with your gastroenterologist.
Thank you. Okay, and then lastly, Lisa asked about anti-anxiety meds. Are they helpful for Crohn's? She said she saw something about that.
Yeah, so great question as well. We can say that anti-anxiety medication, just like psychosocial therapies of whatever sort, just like certain forms of adjunct diets, are going to be probably good for your symptoms, that clinical remission component of things. Okay. Whether they actually treat your underlying inflammation, get you to that mucosal remission or deep remission, we don't know. It doesn't look like that, but maybe there could be a potential role for them, but nothing yet substantial overt in the various studies. But certainly gives you some clinical help overall, which is nothing to sneeze at.
Great. Thank you so much. And thank you everybody for all your great questions. Obviously, there's so much, IBD is so complicated that we all have so many questions. So we so appreciate your time, Dr.
Yeah.
Rabizadeh, to be here with us tonight and do this talk and explain things and take time for questions. And also, if everybody wants, I also wanted to say in the beginning, if some people don't know about our support groups, we have caregiver support groups and patient support group and a lot of other programs. And if you need anything, please reach out to us. And we're happy to provide this talk for you and other resources for patients and caregivers. So thank you. Thank you, everybody. And thank you, Dr. R, so much for being here.
Appreciate it. Thank you so much. And thank you guys for attending and listening. It was great. Appreciate
Yeah,
it.
it's really
Thank
fun.
you.
Thank you, everybody.
Bye-bye.
Good night.